I have David Aden with me. David, you're the chief and editor, and I'm going to let you tell us a little bit about your project.
Sure. Yeah, I'm with the Center for the Study of Drug Addiction Policy, and you can find us. You don't have to remember that entire name. You can find us on the web at CSDAP, Center for the Study of Drug Addiction Policy, csdap.org. And I'm the editor-in-chief for the center, which was started really to take a look at the current opioid crisis and some of the public conversations and public debate about how it's being solved, or how public officials are being told it should be solved. And unfortunately, to a large extent, public officials are being told that they should solve it by giving more drugs.
Right.
And while there is probably, there's a place for medication in addiction, it is not the solution, and it is not the primary solution that we should be going down, and it has unintended consequences. If we just start giving drugs to drug addicts, there's unintended consequences with that, and there's problems with that, and fundamentally it doesn't solve the problem for many of them. So one of the reasons the center was started was because that public policy debate is ongoing, and we were concerned about kind of the direction it was taking.
Right. And as we talked about a little bit earlier, drug addiction goes back to the early 1800s, when there was several very prominent people that were drug addicts. Thomas Jefferson, Benjamin Franklin. Benjamin suffered a great deal with gout, and he was in so much pain that the doctor got him on laudanum. Abraham Lincoln's wife, Mary Todd Lincoln, she was extremely addicted to laudanum along with wine. Laudanum was, you could purchase it in any store. It was legal. So you could go, she would go in and purchase a bottle, and it was known for her to walk out in the street, guzzle the bottle down, and go back in and get another one. She just was a very bad drug addict. Laudanum at that time was legal, and the pharmaceutical companies realized there was money to be made, and later on, they started making that by prescription only, so pharmaceutical and the doctors could start making profits from it.
Yes. Yeah. And we'd mentioned earlier when we were talking too, there was a problem with opium in Chinese immigrant communities.
Right.
And that problem in that community, there was a tradition of it, it was in that community, kind of leaked out into the broader culture. It was bad enough in one community, but then it sort of leaked out into others, so that opium was becoming a problem more generally.
Right.
One of the first things that happened is that morphine was extracted from opium and intended to be a replacement for it. And it was thought, or at least it was promoted at the time, that morphine had all the pain-killing features of opium, but that it wasn't as addictive, and that we would be able to use it to treat actually opium and alcohol addiction. But of course, that was not true. It was highly addictive, and unfortunately, many soldiers found that out during the Civil War. Again, this is sort of the balance here, because there are medical uses for these drugs. If somebody's about to have an amputation, or if they're at the end of life today, if they're at the end of life, these drugs can be very helpful to improve the quality of life or take away some of the pain. But in the Civil War, because it was promoted that there was no addictive quality to it, soldiers were given it, and given way too much and for too long. It became addicted, and now that was the problem. Unfortunately, the next solution for it was developed by the Bayer company out of Germany, which was heroin.
Right.
And heroin was promoted as, this is the solution for the morphine addiction, that was the solution for the opium addiction.
Right.
And I think it's pretty clear what happened with heroin.
Right. The morphine, they would give it to the soldiers. That way, when they were injured, they didn't feel the pain, so they would just keep on fighting. And it also kept them up for days on end. They also used to give it to the kamikaze pilots.
Oh, interesting.
And, they would just, it's like they were sent off for their death, and they didn't even realize it.
Yeah. Well, and historically, if we go back, even hash or hashish was used for a similar thing years and years ago. In fact, if you look at the derivation of the word hash or hashish, it goes back to a similar derivation as assassin, because there were assassins who were kept high on hash years ago. That then part of the manipulation of them to become assassins. So there's a long history of using drugs that way and overusing them. And after heroin, we had methadone. It was developed during the World War II in Germany, came over to the United States after World War II, and was promoted as a replacement for heroin. So now we have methadone clinics around the country. And actually, there's a really interesting sort of story, an unfortunate story about the side effects or the unintended consequences of having things like that. So methadone is given to heroin addicts because we think that it's going to be better for them than heroin and going out on the street. And maybe it is, but it's still addictive. It still doesn't solve the problem. Right. And from what I've heard from friends who are in the drug rehabilitation area, it's much harder to get somebody off of methadone than heroin. They'd rather detox. I have a very good friend who's done drug rehabilitation work for probably 30 years who much rather get somebody off of heroin than methadone because it's so much harder to get somebody off of methadone. Again, we just have these unintended consequences. Opioids have medical uses, but when it becomes a profit thing, when there's a big company behind it pushing it in order to make profit, we get this complete warping of how things are supposed to be and how it's supposed to be used. And then we have this whole range of unintended consequences that occurs.
So the pharmaceutical companies, were they pushing that back in the day that it was non-addictive? Is that because you have pharmaceutical companies that's at the root of all this crisis right now, and the distributors down to the physicians and medical industry?
Yeah, and it's a really good point. There's so many layers involved in this, but just from let's just talk about the numbers for a second, because the numbers I find kind of pretty much staggering. We've heard stories. 60 Minutes has done stories about the opioid crisis. There's many stories out there. You can Google things and find out. A small town in West Virginia that had a population of a few thousand, but 1.2 million opioid pills went through that town over a period of time. And these are all shocking and amazing. One of the things that really put it into perspective for me is the Washington Post had done some research and had spent about a year trying to get details of a government database that tracks all opioid pills in the country. And they came out with an article about a month ago, which is available on their site. They got detailed figures for the years 2006 to 2012, how many opioid pills were sold in the country. Now, we got a country of 320 million people. In a 6-year period, whenever I ask people to guess, how many pills do you think would be, they generally go low.
Right.
The number is actually 76 billion.
Wow.
76 billion pills, opioid pills were distributed in the country in a 6-year period. If you take the 320 million people that live in the United States, men, women, and children, you divide that into 76 billion over that 6-year period, that's more than 200 pills for every man, woman, and child in the country. Wow. And I'm sorry, but on the face of that, you don't even have to go any further. That's just criminal.
It is.
And that level of criminality there were problems with the doctors, there were problems with the distributors who knew how many pills were going to places, with the drug manufacturers that were doing it. So just if we look at the numbers, it's a ridiculous, absurd scene. But there's a whole story of how big pharma, pain management, and a little town in Mexico that came up with a completely new way of marketing heroin. All these three kind of strands came together to give us the opioid crisis that we have today. And when I say these three strands, I'm actually referring to a book that I would recommend to anybody called Dreamland. It was written by a man named Sam Quinones. It's called Dreamland, the true tale of America's opioid epidemic. Mm-hmm. It sounds like it would be a really tough book to get through, but it is so remarkably well written and well researched that it almost reads like fiction because it's just by the style of writing. But Sam really took a look at the fact that the drug companies were involved, the pain management was involved, and it's you get me going here, you won't get me to stop. It's a stop. But there's some really some fascinating story. For example, methadone clinics. I mentioned methadone clinics earlier.
Mhm.
One of the things that Sam found out and exposed was the fact that there's a small state in Mexico that was exporting, bringing a lot of heroin, very high grade heroin into the country in the 90s and into the 2000s. And one of the ways that they found that they could distribute it is they would go to towns where there wasn't already a heroin presence. So they avoided New York, LA, they avoided the coast, they avoided the places where organized crime was already doing it. They went to the small towns, Ohio, Kentucky,
Right.
Arkansas. You go to the small towns, and one of the things they would do is they would find the methadone clinic, and they would go to the methadone clinic, and as the people were standing in line, they'd give out free samples.
Right.
They'd say, here's a free sample, here's a free sample, and here's a phone number. And if you want some more, call us on this phone. And they had somebody sitting who would answer the phone, who would receive the phone call, say, meet us at the corner of Main Street and 5th in 20 minutes. And then the guy on the phone would send out a pager message to drivers who were driving around the town, who had little tiny balloons of heroin in their mouth, about $5 and $10 a month, that they could swallow if they needed to. They would go to Main and 5th or wherever it was in 20 minutes. They'd pass out the balloon. The guy would pay him. This was delivery. This was home delivery heroin that was going on at the same time that the drug companies were pushing a lot of opioids into the environment. And then when that became a problem and then people started to crack down on the number of prescriptions, you now had these people in hometown America who were addicted to OxyContin, for example,
Right.
didn't have a solution. And you had this entire Mexican, I'm just saying Mexican because that's where it came from. It came from a very specific state in Mexico. You had these people doing home delivery of heroin, and they just moved over to heroin.
Right.
And all of this was going on at the same time that the pain management community was saying opioids aren't addictive. They aren't as addictive as we've been taught in the past. So you had all these three things going on, and here we sit today with how many people dying a day? More than 100
Right.
people dying a day.
Mhm. Also, and I don't know how many states are involved in this out of the 50 states, but I know Arkansas, they shut down a lot of pain management clinics. But to replace that come along nurse practitioners, and they're prescribing narcotics.
Are they?
Okay. And I don't know how many states are doing that, but I do know that that's a problem.
With impunity.
Yeah, it's
Yeah, with impunity, it's crazy.
It is totally crazy. When we were talking about the history of opioids, the most recent one that's being used as a treatment for opioid addiction is Suboxone. And one of the, I don't know, it's just so funny how as a culture we approach these things. On the one hand, methadone is federally controlled, and it's only allowed to be dispensed from certain clinics. So that results then in this thing where somebody on methadone has to go to the clinic every day and stand in line. Well, the unintended consequence, and one unintended consequence is that was how this group of pushers were able to sell their heroin, because there was a place to go. So now Suboxone comes out, and Suboxone is approved by the federal government, but it's approved to be distributed by a local physician. A physician can take an 8-hour course to be certified in it, become certified in it. There's a certain cap on the number of patients they can do. But now instead of opioids being given out at one place, now the push is that doctors generally should be giving it out. But how much are you going to learn about addiction in an 8-hour course? You're not going to understand the background. You're not going to understand the social services needed. You're not going to understand the counseling needed. You're not going to understand the diversion of it. And Suboxone is diverted a lot. And not only is it diverted a lot, but one of the articles on the site, if people go onto our site and search for Suboxone, one of the articles in there is from a few years ago. One of the largest settlements, or to that date, one of the largest settlements for an opioid company for mismarketing its products was from the company selling Suboxone. A $1.4 billion penalty against this company. It wasn't even against the companies that sold the opioids that got us in the crisis in the first place. It's the
Right.
company swooping in afterwards to sell us the cure and got hit with a $1.4 billion fine. I mean, it's just, anyway,
That's just like the Sackler family, Johnson and Johnson. The
yes.
and so they were just ordered to pay. Johnson and Johnson was, I forgot how much money. It's an incredible amount. And now there's talks about bankruptcy. So my fear would be they lost the lawsuit, so now they're going to file bankruptcy to where they don't have to pay out all the money.
Yeah, yeah, that's right. And then the Sackler family. The Sackler family is a great example of what's wrong. And in fact, in the book Dreamland that I referred to, there's a tremendous amount about the Sackler family because they were behind Purdue Pharma, which
Yes.
produced OxyContin, and
Mm-hmm.
did a lot of the promotion about how opioids were not as addictive as everybody thought they were.
Right.
And one, not to get into too much into the weeds, but this is an example, I think, of the kind of things that we need to be careful with drug companies, is their marketing techniques. One of the things that was done by Purdue Pharma is they took a letter that was in the New England Journal of Medicine. So let me backtrack a little bit. There was a doctor in a hospital, and I don't remember, the details are in the book, but I don't remember what hospital. He had access to a database, and he liked to sort of run figures based on the database to generate data about patients that had gone through.
Mm-hmm.
And he took about 16, I believe it was about 16,000 patients, somewhere in that territory, who had been given opioids in hospital setting. Okay, these are patients who are in for operations, they're in for perhaps cancer treatment, they're in for maybe end-of-life care, whatever it is. But 16,000 patients, and he found that of those patients, 1% of them became addicted. He wrote a very short letter, a couple paragraph letter to the New England Journal of Medicine, and said, based on this study of 16,000, in a hospital setting, it appears that only 1% of people who are given opioids become addictive. I think you have a sense of probably where this is going,
Right.
which is that letter was taken. First of all, that letter has been referenced in about 600 other scientific articles, sometimes being called a breakthrough study or things like that, that it was a major study. This was a 3 or 4 paragraph letter
Right.
on a very specific case of people in a hospital. Purdue Pharma took that letter, and one of the things they were shopping around doctors is, hey, it says right in New England Journal of Medicine that only 1% become addictive. We're not prescribing enough opioids. We should be prescribing more to people who are in pain to take them out of pain. Okay, well, these are the kind of things that we have to be concerned about. And when I see public policy shifting in the direction of, let's put more people on methadone, let's put more people on Suboxone, that's the solution. There's leaders of public policy in the country are saying that the gold standard of treatment is what's called medication-assisted treatment, using drugs to get somebody off of drugs or to handle an addiction. It concerns me because, as we've talked about, opioids have unintended consequences. There's big money behind it, and
Right.
the drug companies don't make any money by somebody not taking their drug. Anyway.
How do you feel about fentanyl?
Well, first of all, it's phenomenally dangerous when it gets on the street because of how powerful it is.
Mm-hmm.
Interestingly enough, I had a very good friend who actually had worked in drug rehabilitation, drug education for a long time, mostly drug rehabilitation for a long time. Recently had an operation, and in that case, she was given fentanyl and got very worried about it by the doctors. She was given it for a very specific reason, and the doctor explained exactly why he was using fentanyl, and medically it made sense. And part of the reason was she was getting an operation on her knee, but she didn't want to have a general anesthetic. She wanted to be awake during the operation. She wanted to be aware of
Right.
it. And the reason for fentanyl was because it would be very effective to handle the pain, but it would get out of her system very quickly. So it wouldn't last very long. So as soon as they would stop very shortly after that, it would be gone. And so it sounded like there was a medical reason for it. a
Right.
medical purpose for it. However, when you have tons, shipments of it coming in and being laced with everything and killing people,
Right.
that's the problem. This is, again, another problem of the unintended consequences with opioids.
Right.
They always have unintended consequences.
Here's the problem that I have with it. It's made in a Chinese lab where there is no rules and regulations. They don't have, and I'm not a big fan of the FDA, but they don't have anything like that over there to regulate it. So each batch could be different, could have different ingredients, whatever. I don't think there are any two batches that are probably the same.
Yeah.
And it's shipped over here where we have rules and regulations, supposedly. So that just makes no sense to me.
Yeah. No, I agree. And I honestly don't know how the medical fentanyl, what the path is for that to get here. I've mostly heard about the illegal fentanyl that's coming in, being smuggled in, and then being added to heroin and other things. And you're right. In that
Right.
case, we have no idea. And maybe with medical, we have no idea. I don't know that. But
Right.
the push has consistently been to make stronger and more powerful opioids, and to think that we can play around with those things and distribute them broadly and not have a problem it's just naive. It's just naive to think that that's going to be the case.
They like to come out with the new drug, new and improved. And if you'll pay attention to the commercials, um, they have so many side effects that you have to really pay attention to. It's all in very fine print, but those side effects can be fatal.
Oh yeah, absolutely. There's an article on our site that people might want to look at called, if you go to our site and search for tricks of the trade. It was based on a book that I had read concerning big pharma. One of the parts of the book was tricks of the trade, things they do to make their studies look good.
Right.
And there's about 7 or 8 things in there, tricks, ways of setting up a study to make it look much better than it really is. One of the ones that I just thought was astonishing, but they get away with, is, in theory, when they do a study, they're gonna test against a placebo. So they're gonna give somebody something that has no kind of medical benefit at all, and then they're gonna compare the new drug against that. One of the things that's sometimes done with studies is they'll do a 2 or 3 week time period of giving people placebo ahead of time, and the people who respond really strongly to placebo, they remove them from the study. So by the time they start the study, they've already excluded people who responded to placebo really well, and now you're starting with with a skewed group, and now you're comparing the drug against a placebo group that isn't as big as it should have been.
Right.
One of the kind of standard things they do. Or the other thing is they'll do studies. They'll do 8 studies. 6 of them will not show any benefit. 2 of them will. They just do not publish and do not make available the 6 studies, but the 2 studies that are available, those are the ones that they give to the government to say that this drug should be approved.
Right.
It's again, it's big pharma pushing drugs in a way that's really just intellectually dishonest. And one of the things that I find most infuriating is when when that kind of thing comes up and somebody defends it on the basis of it being scientific, or tries to marginalize programs that don't use drugs as not being scientific, when there's so many problems. There's nothing wrong with science. Science has given us great things. There is a problem with corrupted science. There's a problem with science that's paid for by somebody who wants a specific outcome. And particularly in the area of behavioral studies, there's another article on our site about a study that was done of behavioral studies. I don't know, psychologists, psychiatrists putting somebody in a room and testing something on behavior, where if I remember this right, at least 40% of those, it might have been more, it might have even been 60%, but at least 40% of those can't be replicated. So what happens is we hear in the news about this great new study that shows that some behavioral thing that might require a drug. Well, 40% of those studies can't even be replicated by scientists.
Right.
How much value should we put in those? I have problems with the amount of drugs that we're giving to kids. The fact that we have 8 million kids or 10 million kids on mind-altering drugs like Ritalin, things like that. I mean,
Absolutely.
that's a big pharma product. That is not for the child's benefit.
Right. I've heard nothing good come from Ritalin at all.
No, it's basically speed. It's
Yes.
equivalent to speed. So the logic of giving a young child speed, okay, that doesn't make sense. Anyway, I don't want to sound too pessimistic about it, but this whole area of drugs, and in particular when you get into the behavioral side, the psychiatry in particular, has been
Right.
such a partner for the drug companies to promote drugs and promote them widely. The pill for every problem. Somebody is upset with their spouse. Well, okay, well the solution isn't work out the problem with the spouse. The problem is taking an anxiety pill.
Right.
The amount of medication that the country is on is just ridiculous, and that is not for the benefit of the patient. It's only for the benefit of the drug company.
People should do their research before taking those, because SSRIs, the side effects are horrendous. And a lot of the crimes that are committed, if you will look at their past, they're on SSRIs.
Yeah, or coming on or coming off and getting withdrawals.
Yes.
The reactions that some people have on those drugs are just frightening. And I know there's been some attempts to look into the fact that a really, really high percentage of the school shooters that we've experienced, people going into a school and shooting up a school, a really high percentage of them are on these drugs.
Absolutely.
And as soon as you say that, the first thing that kind of comes back and you get hit with is that you're stigmatizing the mentally ill or people who have mental problems, which I think is ridiculous, because what we're talking about, we're not talking about somebody who's got problems in their marriage or their life or something like that.
Right.
We're talking about somebody who shot 5, 10, 15 kids in school, and we're talking about a drug that has side effects that can cause violence.
Right.
Even the FDA has warned against that. Well, I think that's a completely legitimate area to be looking into and to be investigating. There's problems with that because, again, there's a lot of money behind this. There's a tremendous amount of money behind those things.
And the physicians freely prescribe that.
Yes.
The SSRIs, all they have to do is go to the doctor and say, I'm feeling depressed.
Yes.
And they get it. They get what they want.
Yeah, it's true. That's true in that area. It's true with the opioids. Even within the last year and a half. I mean, this is just a friend of mine. So it's, but I think it's probably not atypical. I think it's probably something that happens even after the problem with opioids and opioid prescription in general. She had a really serious skiing accident. Her stature-wise, she was very small. I mean, she's short, she's very thin, very small. So that I'm just saying that physically, that it wouldn't take very much drug to help with the pain. She did have a really bad accident. The pain was pretty extreme. There was a period of time where she needed painkillers. But she told me that she went to the doctor, and it was practically like, 100 pills at a time.
Right.
She managed it by cutting them up and just doing the bare minimum of what she needed. But even in that case, when she did it, she found herself addicted. Over a period of time, she found herself addicted, and she had to wean herself off of it, even though she had tried to manage it. And she told me in the meanwhile, I got a bag of this stuff at my house. I frankly didn't even know what to do with it.
And that the doctors just month after month refill the prescriptions.
Yes. Yep.
I have interviewed several people, quite a few. One had a car accident, and for 8 to 10 years, they kept refilling prescriptions. And every now and then their body would get immune to all of those prescriptions. So the doctor would just add a new one. She was taking 8 to 10 she had fentanyl patch, all kinds of different narcotics. It was just crazy. She was so addicted. She lost her career, almost lost her family. She just about lost everything.
Did she eventually find a way off of them, or is it
Yeah.
not?
She's been clean now for 10, 12 years, but it was a struggle.
Yeah, I'm
It
sure it
was
was.
a terrible struggle. She had like a shoebox full of pills, and they were all prescription. Another thing is people trust their physician. So if the doctor gives them 10 or 15 pills to take, they don't think there's anything wrong with that.
Yes. Yeah, it's true. It's true, and I think there's a burden on the doctors to do it better. There was certainly a burden there, but again, as we've said, it kind of goes back to the industry as a whole, because those doctors were being told it's earlier on that
Right.
it's not as addictive.
Mm-hmm.
The pain management, another element of the whole pain management thing was, they added what was allegedly the fifth vital sign. So you could go into a doctor's office and there's certain vital signs, your heart, blood pressure, and whatnot. The argument for the pain management lobby, if you want to call it that, was that pain should be a fifth vital sign. Well, you tell me how you can tell what the level of pain is from a person coming in, other than saying, oh, this is an 8 on a scale of 1 to 10.
Right.
What's an addict going to say? An
Right.
addict is going to say,
Well, and the problem with that is when they come in and they're in pain, it may be withdrawals. They're coming down, and that is very painful.
yes,
But you don't need more narcotics to stop that pain. You need to find a way to get off from them, period. You know, the pain they're experiencing is not from a car accident. More than likely, it's because they're having withdrawals.
yes, that's right. And as I said, one of the things that we've been looking into is this whole push for medication-assisted treatment, which is what we've been talking about, which is using drugs to get somebody off of drugs.
Right.
And unfortunately, the three thought leaders, two in government and one in a non-governmental organization that helps to set standards for drug addiction treatment, the sort of three leaders in that area right now are very big believers in medication-assisted treatment. I had one of these people, a woman, a psychiatrist at a conference, tell me that the medication isn't there to assist treatment. Medication-assisted treatment originally meant we're going to help you with the withdrawals, and then we're going to taper you off, and we're going to get you into social services. We're going to get you some skills training. We're going to get you whatever you need, nutrition, job. We're going to help sort out your life to handle the underlying or root causes of addiction. She said, no, it's not medication-assisted treatment. It should be that the medication is the treatment, and that there's no reason not to have somebody on methadone or Suboxone long-term, and there's no reason to say that they shouldn't be on those drugs, even if they're not getting counseling. And I just think about it and go, wait a minute, that's just
makes no sense.
It makes no sense. I had her say, I said, shouldn't the preferred outcome be that somebody is drug-free? And she said, no. Somebody who's on methadone, they're abstinent. Somebody who's on Suboxone, they're abstinent. In other words, they don't count as being on drugs, even though we know these are opioids. And this is a woman who heads a main organization that makes recommendations for policies for drug rehabilitation groups.
That's what the problem is.
Yes.
If you don't consider methadone a drug, then there's a problem.
Yes, I completely agree. I'm not a doctor, and I'm fairly confident that I can say that
absolutely
methadone is a drug, and it's an addictive one.
It's prescription.
Yes, exactly.
What are you guys working on now? What is your latest project?
We really try and do a couple of things. One is to educate people. So one of the purposes of having the site is to put up articles, either that we've written, that we've researched and written, or that we see in the general media about some of these topics. And what we try and do is we try and look at those articles and then summarize them, so that somebody who doesn't have a lot of time can go to the site and can get sort of a brief understanding of what the articles are about.
Right.
So education is part of that. We're working on a white paper, which will be a publication that will summarize a lot of this information that we'll make available to communities and policymakers who are having to make these really hard decisions. I mean,
Right.
they're tough decisions about what to do. There's so many things we could talk about. Right, I know that we're going to running out of time soon, but there's so many things we could talk about in terms of alternatives to drug treatment and studies which show the benefits of those kinds of things.
Right.
So education is one, and then advocating for policies that are inclusive of many solutions. In the drug addiction treatment area, there's been a very long-standing principle that there's many pathways to recovery.
Right.
Different people find different pathways. And if at a policy level and a government level, we're saying the way to do it is to use drugs, then not only are we going down a bad path that has unintended consequences, but we're also excluding those other programs, those other pathways that millions and millions of people have used to successfully get themselves over addiction. So I think some advocacy work needs to be done in that area to make sure that we don't lose
Right.
the benefits that we have from these various non-drug organizations.
Are there any policies that are in the works right now to help control opioids and the amount of pills that are being prescribed in America today?
Most of what I hear about is on the level of educating doctors better about prescription of them, and watching more closely doctors who are overprescribing and pursuing those doctors. I think there's been some regulation changes and there's some law changes to try and encourage less prescription, which is good. It's absolutely necessary.
Right.
Even that's not an easy problem, because if you have somebody addicted and then you say, okay, suddenly I can't give you a prescription, I'm not giving you a prescription anymore, where are they going to end up? Well, maybe on heroin. So it's not an impossible thing. I'm just saying that that's the primary attack on it. I think we need to be doing more about non-drug solutions to this problem.
Right. You can't just cut them off cold turkey, because a lot of the drugs withdrawals can be fatal.
Yes.
And a lot of times when the doctors start trying to cut them off or cut back, they're already so addicted that they start buying them on the black market, or, which is way more expensive. Or I've even heard some of them tell me that if they couldn't afford hydrocodones anymore, meth was cheaper, so they would get addicted to meth. And so they were just replacing one addiction for another.
Yeah. Yep. Yeah. Again, I think there's many. I've mostly, unfortunately, focused on in this conversation on the bad news and the problems. I think there's some very positive things going on out there. I don't know if we have time to talk about all of those right now, unfortunately, but there's some very positive things, and that's the other thing that we try and highlight on the site, is the fact that there are solutions.
What is like the most important thing that you see happening right now for the good?
I think one of the things that I was really happy to see is that there was a study that came out very recently looking into the benefits and the effect of faith-based groups on addiction and drug addiction prevention.
Yes.
And one of the unique things about this is it quantified the amount of savings to the United States for faith-based programs. And I'm not advocating one faith over another. That's not what I'm trying to do. I'm just saying the churches that have the AA meetings,
yes,
the synagogues or the mosques or something that are doing things to help educate kids about it.
Mm-hmm.
This study, I thought, was incredibly positive, and it identified about more than $200 billion of savings for the country based on these faith-based programs. Okay, well, that's something that from a policy standpoint we could encourage. We could try and again, without interfering or preferring one religion over another, we could do things to help make that do more.
Saying that, in the community where I live in Southwest Arkansas, there is a lot of faith-based, and I'm seeing the community grow, and it's growing. We have, of course, we have NA and AA, and we also have Celebrate Recovery, Got Time Ministries,
Mm-hmm.
and there's probably more. And I hope that I'm not leaving any out, because the churches are coming together. They don't care if you're Baptist, Methodist, Catholic. It doesn't matter. They
Yeah.
want to reach out and help you. It doesn't matter what religion. So I hope more communities are doing that across the United States as well.
Yeah, me
It,
too.
it takes everybody. It takes the entire community to help families that are struggling with addiction today.
Yes. Yeah, that's totally true.
I don't know the numbers, but I know every family either has a friend or a loved one. They have someone that they know that is suffering from opioid addiction or some form of substance abuse.
Yeah, it really hasn't spared any family. It hasn't spared any geography.
Right.
It's a problem that's excuse me. It's a problem that's affected everyone. Um, and in some ways, it's not surprising because of all the money that was behind it and it was pushing it. And I think that's one of the things that we really need um, to get a handle on. For example, the number of studies that are done and funded by drug companies that come out then in favor of a drug which the FDA approves. I mean, all of this kind of thing. We need to really look at how are we approving these drugs? How are they getting through in the first place? And then what kind of warnings are we giving people about them once they are on the market?
Absolutely.
Yeah.
We're out of time, David, and
Okay.
I cannot thank you enough for coming on. As hopefully some new policies will come out, I'll get you back on. We'll update everyone. If anyone has any questions, they can drop them in the comments, and we will get them answered. You and I can help answer any questions. And I want to thank you for coming on today.
Thank you very much for having me. It was a pleasure to talk to you, and what you're doing is great to give stories about real people and the situations that are out there to help raise awareness. I think it's fantastically important.
Yes, it is. And if we all work together, we can make a difference.
Absolutely.
Okay. Thank you very much, David.
Thank you.
Please support our sponsor, renovationtea.com. You'll find a large variety from daily to specific herbal remedy teas, all certified organic and fair trade. Use code SHATTERED and you'll get a 10% discount. You could see the link below. Hi, I'm Dee. I'm the host of the Shattered Podcast. Please like, subscribe, and don't forget to hit the bell on the notifications so you won't miss an episode. I'm very passionate about helping families. If you are an expert that would like to help or would like to share your testimony, please contact me. Thank you.